me. Erin has been such an amazing person. I'm so happy that you're part of all of us. So I feel like I'm part of you. And so I'm grateful to be here and also to be with you through this journey. Today we're going to be talking about a little bit different of an avenue. When someone has had this disease, where it is in 5 years, what's happening to you? What's changing in you? And this is, again, I want to make a disclaimer. We're going to talk about a lot of things, but a lot of things you will never have. Because as you know, all of us, when you have Parkinson's, you're different from every single person that's sitting next to you that has Parkinson's. And so when you're learning about what can happen or what cannot happen, you need to understand that that may never be a part of your life, but I need to make sure that I cover everything, so I'm not missing out on opportunities with people that do have some of the things we're talking about, okay? And so the first steps is that we're going to be talking a little bit differently in regard to what is Parkinson's at 5 years and beyond. And so please, if you have questions, hold them till the end. I'm happy to talk to you and be with you this whole day if I need to make sure you feel very comfortable about the information that is being provided to you, okay? So I'm going to have a quick slide just because I think it's important about what is Parkinson's. So again, Parkinson's is a dopamine deficiency. It can happen from so many different reasons. We're still trying to figure out why it happens to a lot of people. About 30 to 35% of people have it from a family member, a genetic change in you that actually turns on a gene that starts the Parkinson's process. Some have it because of inflammation. Why is inflammation happening? And we don't know, so we call it idiopathic. What a word, idiopathology. We don't know what that means, but we're getting there. We're getting there every step, and that's another really exciting thing to talk about today. I mean, the research that we're trying to do, and we'll talk to you about opportunities that you have going forward, and I'll tell you a little bit about a story that happened in February of this year that has changed my life and has given me hope tremendously for this disease and for you. And so, again, Parkinson's is a dopamine deficiency, but we're learning so much about why dopamine deficiency happens, what happens to the neurons, what happens to you outwardly, and what's happening inside you. So these are some of the cardinal symptoms. And again, as you can tell, some of the symptoms are a little bit different than what you would see when you see a new onset Parkinson's diagnosis. You may actually see different things. I mean, stiffness, slowness, tremor, walking changes are some things that you have when you go see a movement disorder specialist, a neurologist, or your primary care doctor. But you may start noticing changes in you that are a little bit different, maybe some sleep disturbances or some mood or cognitive changes that you may have not experienced before, and now at the 5-year mark or beyond, you shouldn't have noticed them. So it's very, very important that you talk to your doctor about some of the symptoms that you're having, because it could be Parkinson's related, or it could be something else. And you always never want to miss out on that too. That's something that I want to be very clear about. A lot of times people have symptoms and they go, oh, that's Parkinson's. Oh, that's Parkinson's. Oh, that's Parkinson's. And it doesn't necessarily mean that it is. So you have to make sure we do the investigation for you, and your doctors do the investigation so you don't miss out on something that may be completely different from the disease. Okay? These are the stages, because everybody's always asking, what stage am I in? What stage am I in? Again, please realize that this is just a guide. This does not mean that you are in this stage or that stage and ultimately you'll be here, okay? It's just that I want to make sure that you're aware that there are stages. And we have to figure out how to stage, because they want to figure out where you are in this disease state. But it's not necessarily, some people have a 1 and a 2, or 2B, or 3B. And does that mean that you can't get back up to B2 or whatever? It's one of those things where to define somebody by a number is not the right way. And so I just want you to know that there is a Hohenjar scale of stages, but it doesn't necessarily mean a lot based on what we're trying to do to help you in reverse disease, right? That's what we're doing, right? That's what we're going to do. We're going to walk forward with that. So ultimately, this is another slide, very, very busy slide. Please forgive me, but it's super important for you to understand that a lot of times you can have symptoms way before you have any motor changes in your body. You can have sleep disturbances, constipation, lack of smell, 10, 15 years before you ever have any motor changes that actually bring you to a neurologist. So talk to your primary care doctor or someone like me, which is a movement disorder specialist. And so I've never jumped and propelled myself out of bed when I'm having a dream. Because normally we're paralyzed in our dreams. Because dopamine dopamine helps our melatonin paralyze us in our dreams to keep us safe. That's why they call it REM sleep, rapid eye movement sleep. Because the eye centers, movement centers, are different than everything else in your body. And so if you're acting out in your dreams, you want to be able to talk about it, address it, so we can help you. Whether it be a little bit more dopamine, like before you go to bed, or melatonin, or clonazepam, those are the main things to treat this acting out in your dreams. And that, again, if you're not sleeping well, you're not going to feel as well when you wake up in the morning. Stage of difficulty swallowing, again, we always ask you that question. This may never happen to you, but sometimes you have an excessive amount of saliva, and it's going down the wrong tube, and you're coughing. And so we always want to make sure that you're not having too much saliva, and when you lay down and cough, we always ask that question as well, because we may need to treat your saliva, because you're not making more saliva. You're ultimately just not swallowing on a regular basis. That apparatus is like swallow all day long, which we do when we don't even realize it. You may not be doing it as much. So you start to pull a little bit and you have a little bit of saliva sometimes. And so we want to make sure we can treat that. There's a lot of ways to treat it. So I'm just addressing some things that you may see 5 years or longer. You may never have that. But again, I just want to make sure I talk to you about it. Falls and fractures. Why do I put that on the slide? Well, because I want to make sure you know how to prevent a fall. That's why physical therapy is so important. That's why occupational therapy is so important. They can look at your house and go, no, that's a fall risk, that's a fall risk, that's a fall risk. And it's important for you to make sure you know that. Because you may not know that little rub that looks so pretty in your bathroom. It's not the best thing for you. And so that's why it's important to have an evaluation, a safety evaluation when you're at home. So managing complications, we talked a little bit about cognitive changes. What does that mean? Well, you may have some short-term memory difficulties, some word-finding difficulties when you're having a conversation with your friend or your partner. And you're like, this is different than what I'm used to. What do we do about that? Well, we need to assess you. What's going on? Is it a normal aging process? Is it that we're not really reading out loud, we're not working as much, so we're not having an opportunity to actually be involved in keeping that mind sharp? Keep your mind sharp. So how do you do that? Well, cognitive therapy can help you. Sometimes just reading out loud, that wonderful paper you read every day, out loud gives you an opportunity to hear your words. It allows that your word finding is much, much, much better. And that is also clinically trialed to be very effective. Again, you may have to go somewhere because nobody wants to hear you talk out loud, but it's so worth it. And so that's opportunities. And so neuropsychological testing, that's something that we do in a lot of people to evaluate is there a mood-related component about cognitive changes, or is it more cognitive issues that we can actually work on. Neuropsychological testing is long. It's 4 hours, 3 to 4 hours. And what it does is it evaluates what domains are difficult for you so you can address them the right way so we can help you in a better way. Whether it's your memory or all the other things that you're going to be having issues with. It may be something so simple as you're not sleeping well. And you get you some sleep so you can actually lay down those new memories and feel good. So that's why it's important to talk about this. Because then we have an opportunity to be able to help you. We talked about the stage of workout, so saliva management. And packaging drops you put underneath your tongue, and that diminishes the amount of saliva. Some people do botulinum toxin in the areas to actually just stop the amount of too much excessive drooling or saliva, and it lasts for 3 months. Sometimes it does before we catch work. So I just want to make sure that we don't miss the opportunity to talk about this because it's important. Because again, we need to make sure that you can eat and feel good. And, I mean, I'm a foodie because I'm not eating. So I want to make sure that you keep that opportunity for yourself, okay? And then follow up questions, we talked about that already. Healthy lifestyle. You are what you eat. Your brain is about 75% water. If you're not drinking water, guess what? You're going to feel dehydrated and you're not going to be able to think as well. The brain is not going to work as well if you're not hydrated. Again, you're going to say, well, I have so much excessive urination. I'm not sure if I want to do that to myself because I'm going to the bathroom all the time. So we address every single system. We have to. You know, I become your primary care doctor for Parkinson's because it goes from head to toe. And it may not be for you. You may not have excessive urination, but the other person may. So you have to talk about it. Some people get up 4, 5, 6, 7 times at night to go to the bathroom. You can't even sleep because you're waking up every 2 hours. Is it because you're dopamine deficient? That's very possible. Remember, the motor system, you have a dopamine deficiency, they don't work as well. So the bladder's a muscle, right? And so if you get spasm, which means it cannot hold all that urine in it while you're sleeping, so it wakes you up all day long, all night long. And sometimes it's an easy fix where you just do a dopamine medication when you first wake up, and then you sleep the rest of the day. So you just have to maneuver and figure out what it is that's happening to you so you can help you. I love Tai Chi, I love boxing, I love walking, I love dancing. Anything you can do to move your body is going to help you, I promise you. Why is it so important? I know you've heard this a million times, but you're telling your brain what you want to feel. You're telling your brain how to move. And so if you don't move it, you lose it. I hate saying it because everybody hears it, but it's true. And so you may notice that you do great, and then one day you say, I'm going to skip it today. And then you feel not so good. And you remember, oh, okay, if I don't move, my body's going to feel much stiffer, much slower, and it's not going to remember what to do. And that's why you have to keep on moving. And of course, the engagements are quite good today. So let me go back real quick. So some people, as time goes by, notice that their medications aren't working as well. Or they're living by their medications. Okay, what time is it? Okay, look, I'm off. Okay, did it even work? Okay, I know I took it, and I still feel stiff or slow or tremors or not feeling so good. Because everybody has different feeling when they feel off. So you have like a feeling of off. And you can't explain it, but you know when you're about to go off. And so off and on. So at the beginning of this disease, you may not notice it off and on. And then in time, you may notice that you need a little bit more medication. You're like, oh, I think my doc's going to give me more medication because this is how I'm feeling. Let me explain to you what's happening. It's not because your body's getting used to medication and it's just not working as well because you're so used to taking it. It's not that. It's literally over time, you lose a little bit more dopamine up here. So the goal is to actually just supplement better up here. Does that make sense? And so some people are going up 1 tablet 3 times a day. I'll just call it carbidopa if you decided that's what you're on. And you may need 1.5 tablets, or you need to change the timing of things. That's why I have at times, usually around 3 years or on, I have you do a PD diary every half an hour. Let me evaluate what's going on. Because sometimes you don't remember when you're with me or whoever you're seeing. And so getting an opportunity to understand what is the gestalt of your day. Okay, looking good, okay, I'm having some tremors. So you check these boxes every half an hour, which again, we'll talk about the clinical trials, which is ultimately what you're doing a lot of. When you do clinical trials, you evaluate what's going on with you throughout the day. And you do a lot of diaries for us. So it allows us to understand what we're doing the right thing by you. Can you hear me louder? Yeah. Okay, so and so, thank you for that. So if you are feeling like you're having off time, and you feel like the medication, you're living by your medications, we're going to talk a little bit more about some of the advanced treatments, but advanced is an interesting word. So I have some patients that have just switched straight to some of these different medications and treatments, just simply because there was a decision of, okay, I want to make this easier for myself. This sounds like a better treatment. And again, it's all an educated decision. So let's talk about deep brain stimulation. So some of you may have this. It's pretty amazing. What happened to me is I was a rehab doctor for neurology. I did my first fellowship in neuro rehab. As you can tell, I love to exercise. And if I can help that and get that information to you, it's so important. But I walked in the door, and I was on my day, and I had a patient come in with a wheelchair. And after about 4 days, because he was there to get stimulated, basically programmed, for 4 days straight. And this man had really bad tremor. He couldn't walk. He was very, very much stiff and slow. And by the 4th day, he walked out of that rehab center. Is that for everybody? No. But that changed my life. I have to do this. So I went back to school, did my fellowship in movement disorders, and I haven't looked back. It's been amazing because of the fact that there's opportunities to help you with all aspects of what I've learned through rehab and now with the movement disorder fellowship. So, deep brain stimulation, what is it? It's stimulating the area of the brain to decrease the amount of stimulus from the neurons that are overly acting in you. These are simple terms. Basically what it says, okay, you have tremor. Let me just change those neurons so that actually it calms that down so that you're no longer having that. So it's a second, you usually have some medication on board for improving cognition, but it can diminish your number of medications by half or even more, and it can change the opportunity because it's always with you. So if you're having an off time, the nice thing about it is this is here with you at all times. I'm putting my hand here, but usually you have a battery pack here. It's a lead that's placed in one of two locations in the brain, tunnels underneath the skin, and is in the battery pack, and that's where your programming is. So deep brain stimulation, there's 3 different companies that have deep brain stimulation: Boston Scientific, Abbott, and Medtronic. And so you may have heard of some of those, and if you have questions later, we'll be happy to talk to you about it. But that's one treatment. Second treatment is Duopa. It's been around for a long time. It is a continuous infusion. It is a surgery that is placed a conduit or a tube in below the stomach and gives you active levodopa all day long. Okay? Ultimately, that is something that is delivered in the intestine, and it allows you to absorb the dopamine better. Because a lot of people have gastroparesis. Some of you have heard of that. Gastroparesis is slowness of the gut wall. And so sometimes the medication never gets to what it needs to be. So that's when you have dose failures or suboptimal ONs. And so sometimes you have to bypass the stomach somehow. So there's other treatments as well. We'll talk about this first. So next, this came out about a year now. So this is called Crexont. Crexont is a medication that is still carbidopa levodopa, but carbidopa levodopa in a different way of delivering it to you. So the whole goal of this medication is to go into the right place, the most maximum good place for it to be absorbed. And so this has been around for about a year, and I have about 275 patients on this medication, and many patients have said it's their golden bullet in regard to having the medication on, not having to wait for opportunities to be able to feel like they only have to take a couple doses per day. And so I can talk a lot about this, but ultimately I just want you to know this is a new medication. We haven't had something really, really new for quite some time, and this has really helped a lot of people. So that's one of the options. Onapgo and Vyalev. These are the new pumps. I know a lot of you have had an opportunity to learn about these. And so as time goes by, a lot of times after the 3, 4, 5th year, your stomach can start having some slowness of the gut wall. Opportunities where you have more constipation, where the absorption opportunities for medications are not as good. And so if time allows, sometimes we can get you out of the constipation by doing a whole lot of constipation medications and changing, of course, water. But if things are still there and you're still having difficulty and you're wondering if the medication's going to work today, then sometimes this is the best option for you. It's subcutaneous, meaning that it's a small little needle, and I believe they're both here today to teach you. Very well tolerated. It's almost like an insulin pump. The pumps are 2 different sizes, as you can see here. You're happy to touch them, feel them, understand them. But the nice thing about it is that it can be continuous for you. So that off time is very minimal or not at all. And the other opportunity is that we set a rate for you, but you also have an opportunity to actually give yourself an extra dose when you need it. Let's say some people feel like, wow, my medication wears out a lot when I go exercise. Well, you can have an instantaneous seconds opportunity to have a boost without saying, is my gut going to work today? And that can happen a lot. And so that's an opportunity for you too. And these literally just came out, so it's so nice to talk to you about this today, because we have so many more opportunities that we had, compared to a year ago. And so it's nice because things are changing so dramatically in Parkinson's and treatment that I'm excited that we're here today and not 25 years ago. Okay, what a difference. A decade next, but okay, things have changed this year so much. So we'll talk a lot about that with Dr. Becker's talk too. So, focus ultrasound, if you're wondering. So focus ultrasound has been around for quite some time for action postural tremor. You're maybe asking, what's the difference? So Parkinson's tremor is usually a rest tremor when you're distracted. In time, it may become an action postural tremor as well. Just this is the progression of the treatment. So some people are like, I just can't put my mascara on and such anymore. Anyone can say that. And ultimately that can be an action postural tremor, which is a different disease state. It's called essential tremor. Or it can be Parkinsonian. Parkinsonian tremor, this location of the focused ultrasound was just approved. It's been approved for tremor predominant Parkinson's disease for many years, but we weren't really using that location because we were having more side effects than we would like. And so I was waiting, again, it's something that I saw in my patients. And so we held out, and I had a lot of patients on this clinical trial at Stanford. I just could not wait to have this opportunity for someone that has tremor that they just cannot, sometimes medication doesn't help tremor. And so you're like, oh, I don't feel slow, but my tremor is still there. So there's other options for you. There's deep brain stimulation, and now we have this. And so what is this? This is a non-invasive way of getting, please forgive me, lesioning of an area that's overly zealous and telling you that this is the way that movement should be. And so yes, it's for Parkinson's patients that have tremor predominant, and it's a work in progress in regard to hopefully someday they'll be able to do other predominancies such as stiffness and slowness, but right now it's quite a big win for us. We've been waiting for this for some time, and I've had some really great successes, and we've only had this approved for not too long, I can't remember, a year? Maybe a little bit less.
July 23, FDA approval.
See the difference? I mean, this year has been amazing. We have so many, yeah. And I've been waiting because I had patients I've been following for 5 years from Stanford, and they're like, I go, well, we can do this, but I don't know about the location. So now we have a location that doesn't cause as many side effects, and I haven't had any side effects with my patients and the people I've talked to. But how nice it is to be able to have something that's just one treatment and it's done. Again, you may have you have to manage the other symptoms of Parkinson's, but it would be amazing if you have an opportunity to just have steadiness and peace with the tremor. So that's another option for you. So some of you may have heard that there's some new technology happening with one of the systems called Medtronic. So they are now having an opportunity for someone that has tremor predominant Parkinson's disease. Again, that's going to change, I'm sure, over time to have dystonia and bradykinetic slowness of people's movements is their first symptom, for this to be a possibility for you. But this is pretty amazing. I've had opportunity now for 4 patients to be able to undergo this. What does this mean to you? Well, I'm sure all of you heard about ChatGPT and AI, and oh my gosh, it's overwhelming. But the beauty of this is that it's actually allowing the brain to sense what's happening. And so if you have a threshold where you're about to have tremor, you can, in real time, correct that. You not even knowing it, because we set parameters of the floor and the ceiling, where if it starts to see a little bit of that signal that you're about to have tremor, stiffness, and slowness, it modulates it for you. So a lot of times when you come and see me, 1 month, 2 months, 3 months, we do programming, DBS programming. That's a program I give you. And sometimes I give you another program if you're sitting. I give you a program if you want to talk. And it's interesting, I know it sounds funny, but there's a lot of different ways of actually managing your disease. With DBS, you can actually now, and again, I have 4. I didn't have 4 right now. So we're working on it because I haven't seen enough. But from the understanding and all the amazing clinical trials, is that the goal is actually to have it sensed for you. So your symptoms are controlled before you even know you're going to have them. And so it's amazing. So things are changing. So research and future directions. I want to tell you a story. So I've been wanting to do research, significant research with Parkinson's since I started this wonderful journey with you. And in February of this year, I had this man come in, walks in the door, and he says, hey, do you know who I am? And I said, I've seen your face, I've met you once. His name is Stu Isaacson. So Stu Isaacson is a really well-known researcher in Parkinson's disease. He has a very big center in Boca Raton, Florida. And he decided, because it was so successful, that he wanted to build the 4 pillars, which means 4 different sites in the United States to build this opportunity. So the first one was Long Island with his brother-in-law, built a wonderful center. And then from there, one of my best friends, Linda Grellman, in Northern California, built a center. And then he said, hey, I want you to do the center down here in Southern California. And so the beauty of that is I'm like, who are you? And then I said, okay, let me, he said, well, do the sniff test. Call all your friends so you know who I am and you know that I'm for real. Because I've wanted to do this for so long. It's super hard to open up a research platform by yourself or with a lovely colleague like Dr. Thakkar. And so the idea was, if you can have an opportunity, would you take it? So I did. So now we have 8 clinical trials for Parkinson since February. And we're about to have probably 12 more. We just don't even know what to do with ourselves because every day is a site visit. But they want the opportunity to have the demographics. So imagine having different people from different places. So and having different patients. So you have a demographic that's real. Because you want as much real time as possible when you do a clinical trial. So you have an opportunity to make sure that everything that you're experiencing, everything you're seeing in your data is real. Okay? Because we do one site. It's only that population. Are they exposed to different things? There's something what is it going on in Florida? Okay? But this is nice to be able to have all 4 corners that it helps us opportunity to actually build and push clinical trials as quickly and as efficiently as we can. And so with that, these are the clinical trials we have. We have many more after this slide was made. We already have 3 more in the last week. So the nice thing about it is you have opportunities. You have opportunities to actually be a part of clinical trials that are maybe slowing the progression of disease. Again, he'll talk about that today. I'm so grateful to that man walking in my door because I finally have an opportunity to feel like I can give you what we have now, but also hopefully give you hope moving forward, which is what I need as well. I've been doing this for 15 years, and I need it just as much as you do because you are my friends. You're my family. I see you. And so if we don't have opportunities for you, it feels like you're just going through the days and emotions. I don't want you to have to do that. Thank you so much for your attention. Have a good day. Oh, you have a question first. We're going to have a question and answer. And after, yes?
Oh, look at that. Ooh. What are you doing? No, you won't hear me sing. Actually, you are in luck because you were so efficient.
Thank you.
You actually have about 5 or 10 minutes to take questions, even though we do have plenty of questions for afterwards. Let's have about 5 or 10 minutes for questions. I've got the microphone, so I can actually go around. Raise your hand if you have a question for Dr. Bixby. Hold on. I'm getting in my steps today. All right, our first question.
Good morning. I heard when you heard your slide, you had part of the just autonomic dysregulation. I've never heard that before.
Okay, let's talk. Can you hear me okay?
Yes.
So autonomic dysregulation. Thank you for the question. I didn't want to go overboard, but I do want to talk about autonomic dysregulation. So what is it? So we have 3 different nervous systems. We have central nervous system, which is our brain or spinal cord. We have the peripheral nervous system, which basically makes us move all our peripheral nerves. And then we have an autonomic nervous system. Our autonomic nervous system is our automatic system. It allows us to breathe when we don't think about it. Makes us blink when we don't think about it. Makes us our gut to basically ruminate and absorb foods and medications and everything else without us thinking about it. We don't think to do that. You know, all those things are part of your autonomic system. Heart rate, blood pressure, allowing the blood to move over and you get up and you stand up and the blood, the muscles kind of engage and you don't get the lightheadedness. So that's the discussion you have to have. So autonomic dysregulation is it's not regulated. Okay, so what happens is maybe your blood pressure goes down when you stand up. We're supposed to be doing the opposite. Because normally when the gravity works against you, like you stand up, some people get a little lightheaded. I still do when I bend down really fast. But you have this moment where your nervous system is kicking in and giving you that blood pressure to get the oxygen to the brain so you don't feel dizzy. Okay? So orthostatic hypotension is one example of autonomic dysregulation, where your body is not kicking in when it should. And so that's why we work with having some electrolytes in your water that gives you a little more salt. Why would it be that you would need salt in your bloodstream. Pardon? Exactly. And so the beauty of it is that if you have a high amount of salt in, you have salty blood, guess what's going to happen? Your body always wants to find balance. So it automatically wants to rush the water in and make it the same amount of scenario than it is the rest of the body. And so that's why if you're hypertensive, high blood pressure, don't eat salt. Because you're going to have more and more rushing of the water or the fluid into the vessels and you're going to get higher blood pressure. So it's the opposite is true. A lot of people carry little salt packets. If you have orthostatic hypotension, sometimes you need a medication for it. Midodrine, Florinef, Northera are medications that actually treat that because it's so common in Parkinson's disease, you don't want to miss it. And so when you see your doctor, you say, aren't you going to check if when I stand up, my blood pressure as well? I'm going to ask that question because you need to know if you have this. Because orthostatic hypotension can be just very subtle until it's not. That's why if you work with Claire, they check your blood pressure. And they make sure you're nice and safe because that's a fault. Because if you're not getting enough oxygen there, you're going to get dizzy and lightheaded and not feel so good. And that may be the reason why you're having symptoms. And people can give you more and more dopamine, and it gets worse and worse and worse. Because levodopa can lower your blood pressure. So a lot of patients come in and they have 1 or 2 medications on for hypertension, high blood pressure. And I'm like, those are probably going to go away at some point, or maybe a little bit less. And if you don't look at that, because again, systematically we have to look at everything when it comes to Parkinson's, that could be a reason. Autonomic dysregulation is also constipation, gastroparesis, because all these little neurons, eParents, are telling you, okay, peristalsis, move that food all the way down until you get rid of it, okay? And it may not be able to tell you that. The autonomic regulation is not working. That's why you have to work on stool softeners, or Swiss grits that helps you with constipation, or things that actually have naturally help you by water, okay? But there's so much you can do to help yourself, but if you don't know what it is, you may not even know that this is happening to you. Some people have really low pulse. Some people have urination, and that's autonomic dysregulation too. You're telling your kidneys, oh, get rid of it, get rid of it, get rid of it, and that may not be the right thing because you can get really dehydrated. And so the systems, the balance is not as good, so we need to figure out where it is and fix it. And so the beauty of it, there's a lot of ways to treat it, but you have to make sure you recognize it first. That's why I ask you to be an advocate for yourself and say, if my blood pressure is ranging around 108 or something, when I'm sitting down, guess what? What if it's dropping 20 points when you stand up? You won't know until you check. So again, how do you check it? You can do it 3 ways. Supine, lying down, and then you sit up, you wait 5 minutes, you check it again, and then you stand up, wait 5 minutes, check it again. Systolic blood pressure, the high one, the top one, if it drops by 20 points, that's orthostatic hypotension. Diastolic, the lower one, drops by 10 points. Again, happy to write this in, tell you more. But you also have to look at the pulse to help you understand if it's coming from a regulatory reason, meaning that pulses tend to help you. So if your blood pressure is low, guess what your pulse should do? Ding, 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 ding. So it's a plumbing system. You know, either you have the pump working really, really fast, or you have the pressure working to make sure that everything's oxygenated throughout the body. And so that's why you look at those things to actually evaluate if that's something that's happening. But thank you for the question, because I think it's really important that we all know.
Awesome. And Dr. Bixby, I think we have time for one more question, and I had a gentleman who was so eager, he raised his hand and said, I've got a question. It's over here.
Yes, I had my gallbladder taken out a couple years ago, and I was diagnosed with a non-alcoholic fatty liver when I was actually about 20 years old. I haven't had any issues with the liver, but the thing I'm concerned about is taking statin drugs. And what's your feelings on that, with the Parkinson's and the effect in the brain?
So I have to do a generalized answer because I'm not privy to your medical information, okay? Because again, statins are amazing. They used to think that they should be in the water. Now we don't think that. That was when I was going through school. Every single person that came in for a stroke evaluation, even if their cholesterol was perfect, we gave them 80 of Lipitor. 80 milligrams, that's a lot. And then we decided maybe later, 4 or 5 months later, oh, you can take it off if you didn't have a problem with cholesterol. Because they automatically thought that was the reason why. Have we come a long way? Yes. But the idea is there's a lot in the media saying that if you're using Lipitor, you're missing out on some of your good cholesterol in the brain. And that hasn't absolutely been confirmed. And so the biggest thing is a risk-benefit ratio, okay? If your cholesterol is way high, you're more likely to have a stroke or a vascular disease if you don't take something that lowers your cholesterol so that fattiness and those plaques do not become such an issue in your vessels that you no longer have flow. That is when you have to decide if that's the right thing for you. Some people have side effects to Lipitor outside of the brain health. Some people have like the muscle pain and feel a little weak with them, and that's actually something that can be a side effect of the cholesterol lowering medications. And so there's other options now. We're going into the next year. There's so many opportunities outside of using a statin that can lower your cholesterol level, but you need to talk to your doctor about that. Okay? Pardon? So we're changing. There's a lot of opportunities now. I've been working with an integrated. So he's asking, are you a fan of the HDL LDL ratio? So there's good cholesterol, there's bad cholesterol, and there's really bad cholesterol. Okay, and lipids. And the evaluation has changed so much since my medical school days that it keeps on changing and tweaking. Yes, it's extremely important that you have a nice high HDL. Okay, but the levels of LDL, which is the bad cholesterol, and the VLDL, are real, but there's new indices now that they're actually going to be launching soon for you to have that are gold standard to understand your cholesterol. That is not what we've been doing since this day. And so you're going to see those things and decide if that's actually, they'll decide if it's really worthy of you trying these medications, or if you do need a little bit of cholesterol to actually keep yourself safe.
Well, as much as a celebrity rock star as you are, we'll go ahead and conclude Dr. Bixby's session now. So everybody give her a round of applause.